Here we are in Hawaii, and I thought, I wouldn't have thought that I would have made it this far, but just 2 months ago, or two and a bit months ago, Ray and I were in Anchorage at a meeting co-convened by Brian McMahon, Chris Cunningham and Tina Woods from the World Indigenous Peoples Conference. And it was a great meeting, and we had a spare day, so Ray and I decided to go up to to take the 26 Glacier Tour up in Prince William Sound. And so I thought, well, that'll be fun. I've never travelled with Ray before, but I was pleasantly surprised that Ray is a quintessential traveller, and I enjoyed his company enormously, until as I took this photo as we were leaving the Anchorage railway station to go up to Prince William Sound. He said, "Oh, Stephen, I've had a great idea. I think you should actually have a debate on integration, and a debate with not anyone, but with Christian Brachot." And I said, "Are you kidding?" Because whilst we were arguing about that, we passed a very famous place for Australians. This is Captain Cook's Point, or area where he actually got stranded on his third voyage of discovery trying to find the Northwest Passage. So Captain Cook was the discoverer of the east coast of Australia. So Australians are very bonded to Captain James Cook. And this area was called Turn Again Point. And it was called Turn Again Point because every time he went forward, he got blown back. And every time he went backwards, he went forward. So I thought, well, this is what my debate's going to be like with Christian Brachot. And so anyway, onward and we went. And the day was all right. It was cold and windy. And we finally got to the first big glacier. And I realised, well, look, we're sort of watching calving. And calving was something where the glacier just goes off in a big slab and goes into the water and forms icebergs. And I said, oh, and I got suddenly a moment of inspiration. And as we approached one of the bigger icebergs, I realised, bigger glaciers, all these icebergs were forming, and they had a purpose. And it sort of struck me, well, maybe calving, icebergs, falling into the great ocean of the Prince William Sound, there's a little link here between integration of viruses' DNA and into the host nucleus. Because what I saw was these hundreds of little finches, finch-like birds, sitting on this little iceberg in the middle of the Prince William Sound, and they were singing and tweeting away. They were as happy as Larry, and they were contributing to the microbiome of the Prince William Sound. And I thought, there is hope, there is a sanctuary, maybe there is good in integration, because not every iceberg is a Titanic killer. And maybe not every integration is actually going to end up being a bad thing for the cell. So by the time we got back to Anchorage, I said, okay, Ray, you can twist my arm, I'll take on your challenge. So what I'll try and do in the next 15 minutes, which is what I got allocated, is convince you that the integration of HBV DNA into the host cell genome is not relevant. So like any good debater, I was also asked to put it into context, the types of chronic hepatitis B control. And so the word relevant I'll come to in a minute, but the important point was we were going to sort of discuss it in the context of cure. And Marion and I wrote a review a couple of years ago, and just looking at functional cure, we'll make the point strongly that we think in any cure, if you're claiming a cure, there needs to be a marker of immunity. And hence why in our definition of functional cure, Marion and I have included anti-HBs gain. Now the anti-HBs assays, that's another debate, and I think we should have that debate, Ray, the debate about what does the anti-HBs assay mean at the moment in terms of cure. It doesn't mean much, I agree. So having said that, the next thing we had to then do was really, as we prepared for the debate, was actually agree on what a functional cure would look like. And so in the blood, it would be HBV DNA and surface antigen both undetectable, as I said, anti-HBs positive. And clinical trials, you can convince some patients who are actually close to functional cure to have a liver biopsy. You would want to see no CCC DNA, and we wait graciously for the cis-HBV quantitative assay. No pregenomic or pre-core mRNA, implying that the BCP is knocked out. No HBV replicative intermediates like relaxed circular or double-stranded linear DNA, which I'll talk a little bit about today. And if you did an immunohistochemical staining with good core antibody, that would be negative. But you would accept I believe that you would accept occasional cytoplasmic surface antigen staining, because this would probably, in my view at least, reflect integrated HBV DNA. So, as I said, like all good debaters, we have to define your battlefield terms of reference. So the word relevant, in which context, Ray? So I took you at your word, and I'll try and cover the debate in the context, throw down the gauntlet to Christian, under natural history and viral replication, under host survival disadvantage, under host survival advantage, and then I think why probably the main reason that we're all here, and in the context of integration, ability to achieve a functional cure. So I'm sorry this is a jam-packed slide, but what's sort of known about HBV integration, replication, and natural history? And what is known is that the DNA integrations are very frequent, and they occur very early on in infection and steadily increase over the so-called 4 to 5 phases of chronic hepatitis B. In animal models that have been studied, woodchucks and ducks, Jesse Summers and Bill Mason showed integration occurs within 6 days of infection. So it's not as though it's a delayed phenomenon. In cell culture, Thomas Tu and Stefan Urban have showed that it occurs within 3 days. And following perinatal transmission, a significant integration of HBV DNA certainly happens due to the high replication phase in the early baby years, so that by the time that you're a teenager, the level of integrated HBV DNA matches the e-antigen positive acute clearance phase. And Anna Cranver showed some years ago that following even acute infection, integrated HBV DNA can be shown in humans. So the thing that sort of struck me when I started to review and prepare for this debate was that in the context of natural history and integration, HCC really only occurs much later than all the sort of frequent events that we assume and we now recognise are happening virologically, actually 40 to 60 years later, suggesting integration may not be directly causative. And then over the natural history of chronic hepatitis B, not every patient develops cirrhosis or liver cancer, and 80% of patients with chronic hepatitis B actually die from other causes. So many patients who are in the so-called inactive phase of the disease, which is probably where the highest level of integrated HBV DNA will be found, are actually in generally good health. So the second point I'd like to make under this sort of broad heading is the virome perspective. And really, I think we're a bit naive to think that all integrations are bad. As I said, based on my sort of realisation up in the Prince William Sound, up to 10% of our genome is a consequence of multiple integrations, not just from viruses, but also transposons and retrotransposons over many, many millennia, and has given the concept of the virome. The cells that are actually quite robust in generally, the fact that we've got to this stage of our evolution as mammals, I think reassures me that they're pretty well robust against insertional mutagenesis. Otherwise, they wouldn't have made it to this point in time. And so they've developed many strategies that restrict, that would control and minimise and restrict the impact of integration. And I think we know in our own field the importance of the nuclear domain 10 and the structural maintenance chromosome SMAC5/6 complex, how important that is coping and managing with incoming DNA, not just hepatitis B or herpes or whatever, but any DNA, and also transposable elements. So really cells are really tough, and they're survivors too. And so we often sort of give the virus far too much credit. So the other important point is that Summers and Mason also showed in their paper in PNAS that integration is actually quite low. It's not as, even though it occurs early, it's not a high frequency event. And they estimated that one integration occurs typically every 10 to 10,000 cells. So the question that I started to sort of pose to sort of white ant, my opponent, if you like, white ants are a brand, I don't know whether you have them here in America. We have a lot of them in Australia. And so white ants really sort of eat your house up and the house falls down. So is that really enough to drive the liver cancer process? And Peter Revel will be presenting some data later in this meeting about the importance of splicing as the new way of interpreting and considering the impact of HBV replication in cancer. So the view that we're sort of starting to develop is that splicing rather than HBV integrations may in fact be at least another major mechanism by which the virus is oncogenic. And as I said, Peter will cover that later in the program. And when you sort of look at the impact of splicing and how splicing contributes really to liver cancer rather than integration, The famous Alexander cell line from Jenny Alexander in South Africa derived really from a young African male who was infected with genotype A1 HBV, died of liver cancer, and that encodes many integrated splice variants. We know that the hepatitis B splice protein, HBsB, first described from the Pasteur group, from Patrick Soussan, and it's associated with increased cell proliferation and liver disease. Patrick's further gone on to show that secreted splice variants are associated with advanced liver disease. So, but a paper from Hong Kong, from the Queen Mary group, recently showed that the splicing generates oncogenic chimeric integrants in the setting of liver cancer. And these were amazing. And I'm sure Christian will use that as an argument against my argument. But just to sort of give you an idea of splicing variants, here is the linearized version of the hepatitis B genome with the open reading frames up there. You can sort of see here's the major intron that's spliced out. That's a common feature of most of the splice variants. And you also have multiple splicing events as well, not just one single splice event, but this is the major one here shown for you. And over 20 have been described now. And to sort of give you that in a picture, this is from Patrick Soussan's study about the hepatitis B splice protein. And here is the linearized genome. Here's the major intron with the donor and acceptor sites, 489 in particular, which we'll come back to in a minute. And you end up with a novel protein that's a chimera of the pol and the surface, or this open reading frame here. And this is a 10.4 kilodalton protein. Now, interestingly, in terms of its sort of relevance to cancer, 40% of patients have antibodies. It's associated with E positivity and high viral load, where we know that's the case for liver cancer. It's associated with fibrosis, and it produces cell cycle block. So Dan Loeb from the US has shown exactly how splicing actually contributes to HCC. There's a lot of regulatory cis-acting sequences in the HBV genome, and this one here, HM, adapted from the duck model, this gets knocked out or removed in the splicing reaction. And so this regulatory cis element is required for circularization of the of the HBV genome during replication. And when that's knocked out, you get a double-stranded linear DNA. And why double-stranded linear DNA is the culprit is because we know that actually is a major cause or the precursor to integration. And this is a typical HBV life cycle that I'm sure you're familiar with. And I've just tried to capture for you here the double-stranded linear DNA pathway. Why that's important is that Summers and Mason again showed that it's not a rare event. 10 to 20% of replicative intermediates in any hepatitis B virus cell culture system or animal model or a clinic, 20% of the replicative intermediates are double-stranded linear DNA. So this integration driver, precursor, is a very, very, very frequent element. As well as actually being generated by splicing, double-stranded linear DNA can be also in situ primed with the failure of the capped 18 nucleotide messenger, the capped 18 nucleotide ribonucleotide being unable to prime from minus DNA and to generate the plus DNA strand. So there are two sources, at least, of double-stranded linear DNA. And I think Marianne covered this very nicely, is that we learned from the Arrowhead studies of their ARC-520 that the integrated situation is a lot more involved than we thought. So in e-antigen positive disease, in a group of chimps that they studied in their studies leading up to their clinical work, that, and this was published recently in Science Translational Medicine, what they were able to show is that in e-antigen positive chimps, 90% of the transcripts were terminated near the agreed understand polyadenylation signal sequence for HBV. In the e-antigen negative animals, most of the transcripts were actually fused at the 3' end with chimp sequence. So 90% of the mRNA associated with surface antigen actually came from integrated sequences. So this really tipped the balance and sort of really showed that certainly as you transition from e-antigen positive to e-antigen negative chronic hepatitis B, there's an enormous shift in the integration patterns and the rate. And in terms of the double-stranded linear DNA, as Marion also pointed out, what actually is read off. So here again is a linearized version of the genome, X and pre-core, pre-S1 and pol. And really what we do know is that here's the common integration site here through DR1, DR2. And you get typically a fair bit of X and most of the S, because the upstream regulatory sequence for S and pre-S2 remains intact following integration, but you rarely get pre-core-core. So I think that the result from all of this is that surface antigen is expressed from high levels from integrants. And really, you sort of think, well, DNA and biology is not by accident. There's usually a very, very good reason why particular things happen. And so I think the question that I've thought about since Ray gave me this task was that why is surface antigen so important in its expression? So it seems to be so needed for HBV persistence. And really, as a virologist, I hate to say it, but would clearance of surface antigen from the liver result in some sort of immune recovery? And so is there some sort of immunological basis for why you get persistence of surface antigen? And this link to cancer. So if you're ever going to think about cancer in the setting of hepatitis B, then you think about the REVEAL study. And the REVEAL study, for those of you who don't know, was the really amazing study that the Taiwanese groups did, Professor Chen, with the collaboration with Bristol Myers, looking at a huge cohort of Taiwanese bureaucrats, public servants, over a long period of time, and identified the risk factors for liver cancer: high viral load, E antigen positivity, and genotype C. And so Peter Revel in Melbourne asked the question, are these secreted spliced variants predictive of liver cancer in this large Asian cohort? Now, I know he's probably going to talk about this later in the week, so I won't try and steal his thunder, but he's made a very seminal discovery in collaboration with the REVEAL group, is that most liver cancer patients who had elevated spice levels occurred up to 5 years prior to liver cancer diagnosis. You can see here the black dots, and you can see here the grey dots. The black dots were those patients who developed in this prospective study liver cancer. And these are the ones who have greater than 20% of spliced DNA measurable by Peters assay in their peripheral compartment. The grey are the control patients who did not have HCC, and they certainly did not have levels of spliced DNA at that level. So it does look like spliced DNA, rather than integration, will be the key driver. So the third point I'd like to make on natural history and replication relates to, in the context of integrations, is that hepatitis B doesn't need to integrate. It's not necessary for its standard productive replication, as the integrants, as I said, they're not needed for a productive infection compared to the standard retroviruses. And what's really important is that in E antigen positive, and as I said, from the Arrowhead data and the E antigen negative patients, there's this huge difference in terms of almost order of magnitude of transcriptional templates, certainly of the episomes of mini-chromosomal DNA. So really, my first sort of argument against, in con, if you like, for the debate, is that both phases respond well to the current approved therapies of interferon and nukes. And so if integration was important, then you would have seen a huge difference between the E-neg patients compared to the E-pos patients, but you actually don't. So what about survival disadvantage? As I've made the point that the major viral product associated with integration is surface antigen, and it's made in such huge amounts. And again, it sort of poses a question, viruses don't do that unless there's a good reason. And you end up with, in some patients, 1% of total serum protein is due to surface antigen. And that was exploited in the 70s to make the first generation hepatitis B vaccine. But various studies have shown now that surface antigen, this level of surface antigen does probably play a role in persistence by suppressing TLR2 and 9 and also interferon alpha, as well as the adaptive response through MDCs and B cell responses. B cells bubbling around the blood do actually have lots of surface antigen inside them, and that really hasn't been properly explored. But some data that I'm still grappling with, and I do this to sort of show my willingness to sort of at least debate accurately with my opponent. The persistence of surface antigen is associated with increased risk of liver cancer. And that was first shown by M.F. Ewan's group in Hong Kong. But what he made, I thought, was really an important observation, was that this only happens if you lose surface antigen. So in the context of losing surface antigen, you had to lose it before the age of 50 if you wanted to have zero risk of liver, or almost zero risk of liver cancer. But if you lost surface antigen after the age of 50, liver cancer risk was the same as if you still were surface antigen positive. So is there something about age? Is there something about the liver? Is there something about cirrhosis? Because 50 years is typically a cirrhotic stage for these Hong Kong patients. Or is there something weird about the surface antigen? And I think this is a really interesting situation and not really properly explained at the molecular level. Now, what about on the positive side? How about, what's the advantage? As I said, when I had this sort of, apparition that integration like an iceberg could actually be good if little finches can sort of float around in Prince William Sound, that maybe being integration is actually a good thing for us. So we know that evidence from both human and animal studies has shown clonal hepatocyte expansion. This is a major risk factor for HCC, certainly for pre-nodular liver cancers. And DNA integration is a potential initiating event for that. And this is prevalent not just in the later stages of chronic hepatitis B, but also in the immune tolerant. And Marion pointed out Bill Mason's study in gastroenterology last year, which showed that patients or individuals in the IT phase had similar levels of integration to patients with E antigen positive chronic Hep B. And Thomas too actually had shown that earlier in his postgraduate studies using inverse PCR that virus integration and hepatocyte expansion are present in the immune tolerant phase. So you could almost make the argument that clonal expansion of hepatocyte chronic hepatitis B provides a selective advantage in that these mutated cells are resistant to elimination and they're escaping or avoiding the host cell immune response. And so that this clonal expansion is actually a good thing because in spite of hepatitis B, it allows you to sort of go forward and actually survive. And so look, I'll finish up my argument with the ability to achieve functional cure because that's what Ray really wanted me to talk about and argue with Christian, is that does HBV integration really affect our ability to achieve functional cure? And I guess, again, Marion has presented some of this data. It's, I always struggle coming after Marion because I know it's a hard act to follow. But the question that was being asked is that is reversal of immune exhaustion sufficient? And I'd like to present briefly 2 ASLD presentations and 1 in EASL that actually put some light onto this. So I thought really, again, this is from the REVEAL cohort group in Taiwan. They did a very elegant poster, it should have been an oral I think, but anyway, where they looked at soluble PD-1, which is the commercial assay in Asia. You'll never get this in the United States. It's a novel biomarker for hepatitis B surface antigen seroconversion. And what they showed very elegantly was that reduced SPD or soluble PD-1 levels were strongly predictive of the greater chance of S antigen decline and S antigen seroclearance. And these are just the statistics that they're good at, showing that the lower level of PD-1, less than 125 picograms per mil, was strongly associated with a chance of a high ratio for losing S and seroconverting. And again, this is the presentation that Marion alluded to, which is the PD-1 story from, this was a joint collaboration between Gilead and Ed Gaines' group in Auckland, looking at nivolumab in terms of chronic hepatitis B, and it got an oral. And it was really very cautious, carefully, I thought, excellent study. They did a sentinel study to make sure that even 0.1 was safe. After that, they had 2 cohorts, one with the Gilead vaccine, 4774, versus cohort A of 0.3 milligrams. 1 injection, followed out for 12 weeks, followed out for 16 weeks, and they did a 24-week as well. And their primary endpoint, which I thought was pretty ambitious, was a change in surface antigen log levels at 12 weeks following nivolumab treatment. And so you've seen this data. This is, you can see what's happened at week 12. There really has been a drive to surface antigen decline. And in one particular patient, this patient actually lost S and actually seroconverted. But even out to week 24, you can see there is a strong decline of a driver for S loss in the presence of nivolumab. And it was at this time that they were able to still show good occupancy of the antibody in terms of the PD-1. Look, I know it's an anecdote and everyone gets bagged for an anecdote, but I think really this was quite a convincing story for me. There's patients that do actually functionally cure and seroconvert before your eyes are so important to study, and that's what Ed and his group did. And you can see here from week 2 to week 12 is where they had the flare, and the S antigen declined in the red. And what were the immunological events on that? And quite shockingly, I thought, they showed conclusively that from basically baseline to week 12, there was no change in the CD4 activity. And then after clearance, not before, during, but after clearance, something happens to the CD4 cells in terms of their effector memory cells. And same with the CD8 cells. There was absolutely nothing out to week 12. And remember, I'll just go back, from 0 to 12, this is what's happened. You've actually achieved the flare and you've actually achieved S loss. So the other presentation I'd like to highlight in my defense is whether or not on-treatment flares are important and with S antigen loss. And Alex Thompson and Darren Wong at St. V's Hospital looked at, again in collaboration with Gilead, 16 genotype A patients that lost surface antigen during their tenofovir registration 103 study. Now, these 16 genotype A patients of the 54 that were treated, 9 flared and 7 had no flare. And they were pretty intensively studied. These weren't, there was no flare missed in my view. So really, it strikes me as that there are multiple pathways to functional cure. And sort of in my final defence about functional cure, in the near future, it will be possible to target these liver cancer pre-neoplastic cells as nearly all still produce surface antigen. So, like has been discussed for the CAR T story, it may very well be that when Professor Protzer presented her elegant data today, that we'll be able to sort of engineer T cells and do adoptive T cell receptor treatment to be able to sort of eradicate and eliminate cells from the liver. So even if integration was important, then I think with if Gilead buys a company for $12 billion, there's usually a very good reason for it. And so I suspect that this therapeutic approach will revolutionise how we think about medicine. So my chairs, in conclusion, there are multiple pathways to achieving a functional cure, not just a cytolytic as we've been shown to believe, but I think a non-cytolytic pathway equally goes. And either way, it's possible to achieve functional cure, and this does not seem to be affected by integration. So as part of my debate, I offer up in my defence, is the HBV genome integrated HBV relevant? And I hope I've convinced you that the answer should be no. Based on the spliced DNA RNA may be more relevant as an oncogenic driver, that the integration does not really affect the clinical response to current standard of care therapy, that persistent surface antigen positive at least is as important as integration. Clonal expansion actually should be viewed as possibly a good thing. It protects the host from hepatocyte destruction from the host's own immune response. And new molecular-based therapies like the CAR T technology will achieve a functional cure and possibly even complete cure can be achieved. So my take-home message would be to treat early. Still, I think we want to stop that double-stranded linear DNA form from actually getting into an integration precursor. We know that the double-stranded linear DNA form is sensitive to nucleoside-nucleotide analogues, so we should really be targeting that much more aggressively. Just before I finish, I'd like to thank Thomas Tu from now the University of Heidelberg, who very kindly tutored me through the iceberg sort of rich Prince William sound about how to sort of understand integration, and Dan Verdon and Ed Gain from New Zealand for sharing their data. And so to you, Ray, I'd like to say thank you. This is a margarita in 1,000-year-old ice, and we're cheering your good health, and thank you for the opportunity for making this debate. And I can tell you now I had a huge sigh of relief as I thought about the finches on that little floating sanctuary of iceberg. As we headed back to Anchorage, I knew that these icebergs could actually be equivalent to a positive HBV integration. Thank you very much.